Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. Today on the program, we have Health Affairs' very own Michael Gerber to give us a scene report about a CMS conference he went to dedicated to health equity. But first, just so everyone is aware, Health Affairs released a theme issue this week on the topic of reimagining public health. Contributions include empirical research and policy perspectives that focus on creative government solutions. These priorities include equity as a fundamental principle, community-driven approaches to public health, strengthening the public health workforce, and aligning public health with other sectors, including healthcare and academia. Other articles explore ideas on topics such as financial resilience, artificial intelligence, and spirituality in public health. Funders for the issue included the California Endowment, the Robert Wood Johnson Foundation, Kaiser Permanente, the Public Health Accreditation Board, Center for Innovation, and Big Cities Health Coalition. Michael, you were a theme issue editor on this, is that right?
Yes, I was, yeah.
Anything you want to call out on this issue?
Really, nothing in particular, because what's so great about it is the diversity of topics. I mean, you just mentioned there's spirituality as a determinant of health. There's a legal epidemiology paper looking at some of the court decisions during COVID and how they were made and what they can teach us. Funding of public health, racist practices in epidemiological surveillance, and so on. So it's really just amazing how diverse the topics are, and yet how relevant they all are to reimagining public health and moving forward.
Yeah, I know the theme was reimagining public health, but is there any through lines to the papers or to the issue that jumped out at you?
I mean, the through lines are some that we probably already know, which is that there's a real concern about workforce, for example. You know, a couple papers that highlight that, but some others that tangentially mention it, including, for example, the AI paper, both about how that could impact freeing up some of the workforce from some of the more tedious work that AI can handle, but also training a workforce that can use AI and other technology, and how that could impact the education of public health professionals.
Thanks for that perspective. The issue is open access and available for all to read, but you can order your copy in the show notes. Michael, how are you doing today?
I'm doing pretty well. How about yourself?
Doing good. So if I'm not mistaken, last week you traveled to the mythical land of Bethesda, Maryland. Is that right?
Yeah, I made the long 1.5 mile journey from my house to Bethesda.
What brought you there?
So it was the CMS, the Center for Medicare Medicaid Services, Health Equity Conference. I believe it was the second one, but it was my first time attending.
Second year, wow. So I had never heard of the conference before. Can you give the listeners a little bit of insight into what the conference was about? What was obviously health equity was a big theme for a health equity conference, but what were they toting in the agenda?
Yeah, so the agenda, I mean, a lot of it covered something specific to CMS and programs at Medicare and Medicaid and the marketplaces. It was some panel discussions with officials who run different divisions within CMS, as well as other federal offices, talking about just their various equity activities, how they're changing some of their payment models, things like that. So it was partially a chance for them to inform the community. I'd say equally, though, there were panelists from around the country who are doing innovative things, sometimes related to CMS programs, sometimes not directly, just to try to make healthcare more equitable and create healthier communities.
Well, that sounds really interesting. So if you were to put yourself in the reporter's shoes and bring out your reporter's notebook, what were the big takeaways from the conference that you had?
Yeah, so for me, one of them, maybe it's become pretty clear to a lot of people. We've been talking about social determinants or health-related social needs for a long time now, and yet it still stood out to me how much that dominated the discussion and a lot of the presentations, as opposed to talking about health care. Whether you can differentiate those anymore, I guess, is a good question and still up for debate as to who should be providing all those services. But it really was clear that a lot of the discussion was really going back to the root causes and how can we address some of those social determinants of health, like access to food and things like that. And then also where those intersect with healthcare, access to healthcare and just getting people insured or in some of these programs, getting people housing, transportation, whether it's transportation to, get that food that we just talked about as a determinant, or transportation to get to their doctor's appointment or other healthcare needs.
Yeah, so the social determinants, social drivers, health related, social needs space, whatever you call it, I know it's been a hot topic for many years, depending on the name, but it has been, from what I've gathered, like somewhat not a mature market. I don't want to say market really, but not so robust in its program. People are still figuring it out. So, like, did you get a sense of, like, when you look at the interventions from a federal governmental payer space, where they see their role in being able to move programs related to this forward?
Right. I mean, it's definitely clear that they see a pretty big role for CMS and for, traditionally what we think of as healthcare payers to be involved in this, to pay for some of these services, to encourage, healthcare providers, physicians, payers to be directly involved in either providing or contracting or partnering to offer these services. So, for example, there was a session on programs in 3 different states using Medicaid 1115 waivers. So, getting permission from CMS to try these innovative programs through Medicaid to fund housing programs or things like that. So, for a couple of the speakers were Katie Huber and Will Bleezer from the Duke Margolis Institute, talking actually about a paper they published in our housing theme issue a few months ago on what's happening in North Carolina to actually use Medicaid funding to address housing related needs. And that same session had someone from California talking really about, I guess I'll call it a shelter for unhoused, but obviously shelters now provide many more services often than just the physical shelter, and what they're doing under, California's Medicaid program to try to provide housing and other services. So it was really interesting. And they were open about some of the challenges of it too, which is always refreshing. So, for example, one thing that stood out to me, they talked about how, to do these things successfully, they're often partnering with these smaller community-based organizations that aren't giant health systems that we're used to in the consolidation of healthcare now. And they're not used to the same kind of funding model. You can't tell them, hey, provide housing for all our patients and we'll pay you next year, like healthcare happens. So they talked about, finding different ways to provide that funding and going back to CMS and saying, we need to provide some funding up front so they can actually hire the people to provide these services. So things like that.
Did it come up in these services? So you mentioned North Carolina and California, very different states. Did they talk about how these examples might be able to scale up to a national level at all? Or are we still in the state-based approach thinking?
I really didn't hear a lot about that. I mean, CMS is always talking about if things work locally and at the state level, finding ways. Medicaid, obviously, a lot of the stuff is always at the state level, although with CMS oversight. There was clearly, a lot of people from different regions who are considering different things who were running up to the speakers as soon as the session ended to find out more and to try to replicate or learn from the programs in other states. So I think you'll see a lot of things happening more broadly and mimicking each other, but I'm not sure how much will be, especially on the Medicaid side, the stuff I was just talking about at a national level. One thing, if I can add, that I did find interesting about trying to get a more national consensus on was another session I went to. A group of people who I guess at last year's conference realized that there was sort of a lack of a consistent way to measure disparities or measure inequities. And one health system was doing it one way, another was doing it a different way. And some of these people got together and said, we should come up with a way that's consistent that people who aren't doing it yet can look to and say, this is the best way to measure. So they created a collaborative. They partnered with the Institute for Healthcare Improvement. They had a couple meetings. They then presented, and there was a lot of interest in what they're putting forward, which in the next few months, they should produce a report that they're saying will provide some of that consensus on here's how we can measure disparities and what data we really should look at and how we can do this in a consistent way, whether it's Sutter Health in California was one of the systems involved. And then, let's say a system here in the Washington, D.C. area where I am can compare in hopefully a way that allows them to learn from each other and collaborate, not compare in a negative way.
Yeah, put a little bit more structure into a large group of organizations. So, Michael, we have about potentially 3 minutes left. Is there anything else that we haven't touched on that you want to make sure the listeners know?
Yeah, there was, I talked about Medicaid. There was a lot of talk about Medicare, things happening on the Medicare side. I found it interesting, one panel on a topic I'm starting to look into a bit more on sort of value-based care and value-based payment models. So, there was one speaker from Commonwealth ACO, an accountable care organization in the Phoenix area, and they've been an ACO for a while, but last year transitioned to the new REACH ACO model that the CMMI, the Center for Medicare and Medicaid Innovation, is sort of testing out to be a more equitable ACO model. And they joined it, and they've expanded their services to a lot of the rural areas in Arizona, including Navajo County. But it was interesting. Again, they talked about some of the challenges. Everyone there, I thought, was passionate about equity, but clearly money drives things in healthcare. And you could tell that, they got into this model and they thought, as we're expanding in these rural areas, which are underserved, the whole point of the REACH model is to sort of make sure that those places are funded better to serve these underserved communities. And they thought they would, see an increase in the funding they got. They actually saw, a 4% reduction, they said. And so they're figuring out ways to expand their services while also making sure they're figuring out how to get the most money to be able to provide those services. But they're still enthusiastic about growing in these rural areas and think that the model will work for them. It's just going to take a little time. So that was, I think, interesting just to hear that, people didn't know what to expect and we're finding different answers so far, but not giving up.
Well, Michael, thanks for sharing your experience and insights from the CMS Health Equity Conference. It was great to hear. And with that, hope you, the listener, enjoyed this episode. Please send it to a friend that may be interested in health equity and wants to know more, and have them sign up. Check out the Reimagining Public Health theme issue, and see you next week.